Clomipramine is also known under the brand names enafranil and novaclopamine, as well as clomicalm for use in animals. It belongs to a class of drugs called tricyclic antidepressants, or TCAs. It was developed and patented in 1963 by the Swiss drug manufacturer Ciba Geigy. It is used in the treatment of mood disorders such as major depressive disorder, but mainly for obsessive-compulsive disorder, for which it was the first drug to be found effective and approved for use by the FDA. Clomipramine is only administered orally in capsules. Only 50% of the drug remains biologically available after administration due to extensive first-pass metabolism by a collection of CYP2 enzymes in the liver. Desmethylclomipramine, the active metabolite, is absorbed quickly from the stomach. This absorption is not affected by the presence of food in the stomach, but is affected by smoking. Desmethylclomipramine is 97 to 99% plasma protein bound and therefore has a long half-life of around 3 days, explaining the long duration of action. The metabolites are eventually eliminated through urine and feces through a process called biliary elimination. The true mechanism of action for both TCAs and selective serotonin reuptake inhibitors is not definitively known, but there is strong evidence to suggest that they work by inhibiting autoreceptors on the presynaptic neuron. At the synaptic level, we see 5-HT serotonin receptors and both alpha-1 and beta norepinephrine receptors on the postsynaptic neurons. Both neurotransmitters are synthesized in the presynaptic neuron and then released into the synaptic cleft. The released neurotransmitters then bind to their respective receptor sites. When there are excess neurotransmitters left in the synapse, they bind to the SCRT and NET autoreceptors, which allow the reuptake of excess neurotransmitters as well as signaling for the presynaptic neuron to reduce their production. TCAs block these autoreceptors, thus preventing the reuptake and reduction of neurotransmitter production. Tertiary TCAs, like clomipramine, are especially potent CERT and NET reuptake inhibitors. Key symptoms like anxiety, depression, and obsessive-compulsive behaviors have been linked to low serotonin levels. This is thought to be due to a lack of these monoamine receptor sites being available on the postsynaptic neuron. As well as being linked to low serotonin levels, A1 and beta norepinephrine receptors are metabotropic. Normally, norepinephrine would bind to these receptors, which would in turn activate their coupled G protein, which is a catalyst for cyclic AMP production. With reduced norepinephrine receptor binding, this G protein isn't activated, cyclic AMP production is lowered, and subsequent processes are affected, such as cyclic AMP-gated ion channels not being modulated to allow the influx or efflux of ions necessary for the generation of action potentials. TCAs block the autoreceptors, but are not considered agonists or antagonists, as they do not elicit their own effect. They just prevent the binding of neurotransmitters to these receptors. As I mentioned before, TCAs, especially SSRIs, are not fully understood as there is currently no way of measuring serotonin levels in the living brain. It is possible to look at serotonin levels in the blood, but it is not clear whether or not these accurately reflect the levels in the brain. However, it is clear that you should never use more than one substance affecting serotonin levels at a time due to the risk posed by serotonin syndrome, categorized by muscle rigidity, fever, and seizures. Serotonin syndrome can be fatal if left untreated. The desired therapeutic effects of clomipramine, such as reduced anxiety and frequency of obsessive-compulsive behaviors, occur as a result of the increased serotonin and norepinephrine levels. However, the drug also blocks histamine H1 and muscarinic receptors, which result in sedative effects regarding fatigue, as well as other areas such as sexual desire and performance. As with many antidepressants, there is an increased risk of suicidal thoughts within the first few weeks of taking the drug, especially in adolescents and children. This is thought to be due to the fact that, although taking the drug has fast effects on the neurotransmitter level, steady-state plasma levels are only reached around 2 weeks after treatment begins, and so serotonin levels are only increased slowly. When starting the drug, it can be disheartening not to see results. Research has suggested the potential for metabolic tolerance to clomipramine. In a study, elderly patients reached steady-state plasma levels at lower doses than midlife patients did. This could be because younger patients either have greater levels of relevant CYP2 enzymes or have more effective enzyme synthesis mechanisms in response to the elevated drug levels. There is no evidence of long-term tolerance, but this is likely due to the fact that clomipramine is not being advised for use long-term. However, previous evidence does suggest that metabolic tolerance could be expected if used long-term. Withdrawal symptoms such as dizziness, nausea, and vomiting occur as a result of the removal of the block from histamine and muscarinic receptors. Insomnia also occurs as a result of the reduced sedative effects. The most concerning withdrawal symptoms, however, are the sudden relapse of psychiatric symptoms such as anxiety, depression, and compulsions due to the decrease in monoamine levels. The withdrawal of clomipramine should be done gradually and under the supervision of trained healthcare professionals. To summarize, clomipramine is used to treat OCD and major depressive disorder. It belongs to the TCA group, which achieve the desired therapeutic effects by reducing reuptake at autoreceptors, resulting in increased monoamine levels. Clomipramine helps to maintain these monoamines at normal baseline levels, but they will decrease again when drug use discontinues, resulting in some serious side effects.